I'm Dr. Sourabh Kulkarni. I'm an orthopedic consultant and a joint replacement surgeon. I am into joint replacement field since last 15 years, and recently since last 3 years I have been shifted my practice to dedicatedly to robotic joint replacement. I have a hospital, Shri Yash Orthopedic and Trauma and Joint Replacement Center, and practice in Navi Mumbai. I was a conventional joint replacement person initially, and now shifted to a dedicated robotic joint. The only matter of fact why I shifted from conventional to robotic is to have the precision of robotic arm. So according to me, in the market there are multiple robots. Almost every robot is giving us navigation system, but there are three broad categories of robots I can categorize into. The first category can be considered as a passive robots. What are the passive robots? In passive robot, the zig through which the saw goes and the surgeon cuts is usually held by the robot, and surgeon has to do cutting by the regular saw. According to me, a surgeon's hands error or the judgment error is minimized in that, but is not completely gone. So passive system was not the choice for me. Then comes the semi-active robotic systems. What are the semi-active robotic system? There is no zig. The cutting tool, either it is burr or it is a saw, is usually in robot's hand, but it is not propelling it. Surgeon has to propel. I tried to use those, but I found that it is a what you can say, a struggle between man and a machine. Machine is trying to keep it in one direction and surgeon is trying to go in another direction. So you have to fight with the machine, or you have to just have a friendship with the machine at that point of time. That also was not my choice. And the third category which I came across was the fully active robotics. In fully active robotics, the cutting tool is in robot's hand, and usually the propelling of that cutting tool, either it's saw or it is a burr, is usually done by the robot, irrespective of whether the surgeon is there or not. But definitely the controls are in surgeon's hand. So that was completely suiting to my requirements, that to eliminate a human hand error or human eye error or human emotional effects on its cutting. So I chose to go ahead with the fully active robotics. So as we all know now, the robotics is majorly about the accuracy and precision in sub-millimeter cutting. So because of this accuracy, the implant is being placed in a perfect position, 90 degrees, the mechanical alignment or the kinematic alignment that a surgeon is choosing. Then the joint line orientation angle is perfectly managed there. Because the implant is in a perfect natural anatomical shape and size, the patellar tracking is better. Because of patellar tracking, the range of motion is also in a very nice way. Patient has no pain. Usually this navigation part of the robotics gives you in millimeters the gap balancing. So the throughout the range of motion, your gap balancing is perfect. Ultimately, this all leads to lower wear rates. And lower wear rates usually lead to the long-term survivorship of the implant, that is called as the longevity of the implant. And secondly, the gap balancing in robotics is a preemptive gap balancing. What is preemptive gap balancing? Before starting any tibial or a femoral cut, your gap is being shown into millimeters, 8 millimeters, 9 millimeters, 11 millimeters. In conventional, we do cut exactly measured dissection, but later on we come to know that there is 9 millimeters of, instead of 9 millimeters cutting, the 11 mm polyethylene is going. So here, before starting the cutting, we are reducing the tibial cuts or the femoral cuts and keeping the gap balancing at 9. So this leads to bone conservation, and this bone conservation